Welcome, everybody, to our first grand rounds of the new academic year. It is my absolute pleasure to introduce Sharon Schindling Rising. She's a certified nurse midwife who graduated from Yale School of Nursing. She taught on the faculty there and then established the graduate nurse midwifery program in the child rearing center at the University of Minnesota. In 1993 to 1994, she developed and piloted the centering pregnancy model of group healthcare in Waterbury, Connecticut, and began doing instructional workshops nationally and internationally. She founded the Centering Healthcare Institute in 2001 and served as its CEO and president until 2014. In 2017, she and her colleague published the Centering Pregnancy Model, The Power of Group Healthcare. She was on the Yale grant team that conducted the first randomized control trial of the centering model. She was honored by Civic Ventures with a Purpose Prize and was received awards from Yale University, the Academy of Nursing, the American College of Nurse Midwives, and the National Perinatal Association, and the Monroe Trout Premier Cares Award. Sharon is a founding member of the Group Care Global, a nonprofit establishment to support the implementation and spread of group care internationally. Most recently, she is part of the research team funded by the European Union that has just completed a 4-year study implementing centering-based group care for the first 1,000 days with vulnerable pregnant and parenting families in 7 countries, including South Africa, Ghana, Kosovo, Suriname, the Netherlands, Belgium, and England. She resides with her husband and daughters in Philadelphia and worked closely with the board to provide major direction for Group Care Global. Welcome, Sharon. We are glad to have you. Please start your presentation.
Thank you. It's good to be here and have an opportunity to talk with you a bit about group care and its positive outcomes for the families and the clinicians who are using it. So the title of our talk today, Connection is Care. So focusing on the relationship of the clinician, the attendees, the birthing women and parents that are in the group, and the development of the community that happens with them. I don't have any disclosures. So the thinking a little more broadly than simply the prenatal period, our focus on our European grant was group care for the first 1,000 days, from the time of conception through age 2. And ideally, that is how the group would be put together, that people would stay together for pregnancy and then for a whole 2 years. So you can imagine the kind of relationships that develop in a group when they stay together for that period of time, and also how the care would be developed across both sort of dyad care, really, for the mother and also for the babies. Well, healthcare is not a product manufactured by the healthcare system. Sometimes it feels that way, I think, but rather it's a service which is co-created by healthcare professionals in relationship with each other, with one another, and with people seeking help to restore or maintain health for themselves and their families. I just think this is a good overlay for us to remember as we think about how we can best deliver care. So, as you heard in the introduction, I've had a lot of experience with developing the model, and the initially was with the Centering Healthcare Institute, and now I'm with Group Care Global. So a lot of my references, I think, will be international, and sometimes I'll say antenatal and sometimes prenatal. So you know where that comes from. So I thought back to how all of this developed, and this is a picture of me, I think, sitting on the coast of Maine, thinking about how could care be better. So here I was in the position of talking about genetics and thinking about if I could do that just once a day, or having time to feel as if there was opportunity to really discuss what was important to me as well as to the woman coming for care. Feeling really present during my time. I developed this model during a time when we still had paper charts, and I would look outside my room in the chart box and see four charts or more sometimes of women waiting to see me, and that never felt good. So I would really like to feel satisfied at the end of the day that I was able to have meaningful conversation with each person, and thought, well, meeting with a group of women would provide more time for discussion, help to build community, and I'm guessing, because we didn't have data at that point, lead to better outcomes. And if you were a woman coming for care, and you might think right now about the women you're caring for, there was no waiting to be seen at the visit, developing a community of friends, having relaxed time with your midwife or doctor, receiving encouragement to set personal goals, having plenty of time for discussion about pregnancy, birth, parenting, and really having fun at the visits. And that goes for the clinical provider as well. As one woman said, we came at the same time, left at the same time, and something happened the whole time we were there. So, as we talk for the next few minutes, kind of imagine what it would be like to be in a setting where care would be given this way. There would be no waiting. Women come directly to the room, the group visit room, and it was a cohort of the same people. So they really got to know each other well. So prenatal care, this is provided in a group format where a stable cohort of, so usually 10 to 12 pregnant women, and ideally they would be forming a cohort early in the second trimester, after they've had their intake into the system, and then have been invited to get their care in the group. So other women in the group of similar gestational age, and they come together every time for their visits. So unless there's an issue of some kind that needs further assessment, they would not go into an individual exam room. So this is just the quick history, but just to give an idea of how this developed, it's been around for a long time, but I developed this model in 93, 94. And during that period of time, 93 to 2000, I was working in a private office, in a community health center, and in a hospital clinic in Waterbury, Connecticut. So I wasn't aware of what was happening exactly then, but I was actually piloting a model in three different care locations, which turned out to be an important fact, because people would say, well, it will work with this population, but not with this one. And I could say with some confidence, it really works with any population. And of course, that carried over when we started doing the international work. So training workshops were launched, first article published. So there's a lot that was sort of happening right around that time. And the Group Care Global itself, the international work that we're currently doing, was registered as a nonprofit in 2017. So during this time, I was working in a hospital clinic, as you could see, sort of looking for, you can imagine, oh, where are we going to find the right space to do this, right? In a community health center, you can see assessments happen on the floor or on a low cot. There is no use of exam tables. And then in a private office where the couples gathered after work. So we met from like 5 to 7. There are three components, the model, and while we might call it centering pregnancy or centering parenting or centering healthcare, as we did our international work, we called it centering based group care to take away some of the absolutes that might have been there in the original model. So there are three components. The first one is that this is care. So I'll go through each of the components a little bit more, but this is the woman's care. So she doesn't make additional visits unless she has some problem that needs further follow-up. It's a time also for what we started out by calling education. Education to me was having more of a passive sound to it, because what I learned with sitting in the groups and listening is that I was learning as much or maybe even more than the women were. So we called it interactive learning. Everybody learns. And this is a game. They're in the process of playing a game that, because this is fun as well. And then it's a stable cohort of, as we said, 10 to 12 women, same gestation. So there's community building that goes on, and women care for each other and they reach out to each other. So these three components are like pillars that are solidly put in the ground. And while how they're implemented may vary slightly, they are all three important to the model. So as one person said, centering has an almost instant effect on women who immediately understand the difference between this kind of care and other care, being treated in a way that feels more respectful to them. Everyone there speaks their language. This is really significant for people who are being bombarded by a culture that they feel doesn't really see them. And so there are groups that are conducted with various languages to allow for the development of sharing, understanding, and some of the education pieces that we do want to talk about. So I have a few graphics here that I like because I think they sort of tell the story, but they came out of our European Union funded 4-year grant that we have just finished. But group care is about healing and connection. I mean, women, I didn't feel so much alone. We talked so much. It was a wonderful place to be. It gave me confidence. Oh, you too? You're having the same thing that I'm having? Oh, I'm so glad we can talk about this. So this becomes a really important place for all that. This particular graphic is really busy, but this is what happens in the group space, and which is why I like to look at it. All three components are shown in this one graphic. You'll see up on the left, the check-in area, on the right in the back, the assessment area, and then a circle, and then a place for socializing, really. And so many places have food or snacks of some kind, at least water is available to them. So you get a sense for this is all one group space. So looking a little more closely at healthcare, women come, they check their own blood pressure, they keep up their records, they have a graph that they manage. When there were charts, everything went directly on the chart. So you see here a couple women sitting there, they're checking their blood pressure. They also, many places check weights. So in our international work, we found out that the British do not check weights. So the scale isn't here, but usually there would be a scale for someone to check, for each woman to check her own weight. Then there is a low space still within the room, and here the plants are meant to show that it's divided some, that there is something private going on. You will see that there is music playing, which also gives some privacy within the room. And this is a brief, we call this a 3-minute assessment because you don't want to get stuck with going over all of the pieces that you want to talk about for prenatal care. That happens in the group. So this is a very quick check-in to make sure that everything is going well or that the woman doesn't need some additional follow-up. the circle, we might call it circle up when everybody has been seen. There's a gathering in the circle. There's always an introduction of some kind, and there are activities planned because this is about an hour of time. The groups usually run for 2 hours, so from start to ending, and they start and end on time. So during that time, I mean, there are some games, some activities that are sort of part of what would be a reasonable content for that period of time in their gestation. And they get to know each other. You can imagine here, it looks as if they're dealing with nutrition with some nutrition cards. And the third component, community building, we build community in a variety of ways, but one of them is kind of over food or talking around the table and getting to know each other. You might hear, if you're doing the assessments very quickly in the corner, you might hear them chatting about, so how is it going at home? I remember last time such and such was happening. And as they really start to care for each other. But there's this informal time for the community building, and the clinician is also constant. So you kind of own this group. So if you're the resident or the then or the physician, the midwife, this is your group, and so you get to know the women well, and are glad to see them. They're glad to see you. So there's been a lot that's been written, there's evidence base for group prenatal care. My colleague Charlotte Quimby and I put the basic model together. This came out in 2017. The book, The Little Pearls on the Right, is a book that's full of stories, and you can get that online. It's just a great book of women in particular, but also primarily midwives, because this came out of some of the international work, and almost all of the care internationally is provided by midwives. So a lot of really rich detail. But there's a lot of data around if you're interested in really getting into some of the specifics. Uh, so what that early data, and then it's continued to be supported, initially showed improved birth outcomes, sort of much to our surprise when we first started doing this work. We didn't know what we were going to find. All we knew was that it was a fun way to provide care, and the women were liking it. And so we had Yale residents in our first work research. So they liked it as well. What else? Women came more often for more visits. They had better knowledge when they were asked about this, higher rates of breastfeeding initiation, and greater satisfaction. Everybody liked the model when we talked to them about that. And the partners came more often and felt really empowered by knowing more about what was happening, and also getting to meet the midwives. And supportive relationships were formed between the women and the providers. So like this connection was developing and was feeling good. So there were some large RCTs. The first one that was sort of interesting, this was our first attempt to get some data. This is Jeanette Ikovics, who is in public health at Yale, and who called me up one day. She had been to a training and said, "Hey, are you interested in getting some data on the model?" Well, I had been waiting for somebody to ask me exactly that. And so our first study was called Group Prenatal Care and Preterm Birth Weight, results from a matched cohort study. And that happened in New Haven, the public clinics there, and also at Emory at the Grady clinics there. And the initial conclusion of that was that group prenatal care results in higher birth weight especially for infants delivered preterm. And we found some other things as well, but it was all, as you imagine, when you're first starting to study something, and we were scratching our heads saying, well, isn't this interesting? So that was followed with an RCT in 2007, which showed a 31% reduction in preterm birth within the population, and that was very exciting. And many of the ACOG people were very interested in that. Particular nod to Doug Lauby, who at the time was finishing his stint as the president of ACOG, and he came on our board not that long after and provided us a lot of help through the years. So there was another cluster RCT. There was an RCT in Iran, and Holly Kennedy did one with the American military, which showed that women actually came for the number of visits that they needed to in order to qualify for the military insurance. So that was actually, it was a different outcome, but one that was very important. And then there was early work in Sweden with looking particularly at satisfaction. Recently, we've had, you can see, 2025, 24, been a lot of new data that's come out. Much of it is from the European Union funded study that we have just completed. We completed at the end of 24. But the things that have been looked at, the maternal satisfaction and looking at model fidelity, does it make a difference? We are really focusing on group care beyond birth. So getting into that 1,000 days study that is still early in terms of the data for that, but starting to come. And what about the theme of belonging as we think about how isolated people are feeling these days, that there's just a feeling of abandonment for many women, of loneliness, of isolation. And what we find when we talk with women who have been getting their care in getting group care, and who just say, I wasn't alone. I had friends, other people who were going through the same thing I'm going through. So, and you can probably think pretty easily about some of the families, some of the women that you've cared for, and how many of them are wishing that they had more support, how important this community is. And then there's been a lot of work done in Malawi. The team from the University of Illinois, Chicago, Crystal Patel, has published a lot of articles, and this one is really looking at even individually at how women have experienced this group care, which has been going on now for many years in Malawi, and the Ministry of Health is now working on making this part of the reimbursement system. So way back early on, I was talking with actually one of the Surgeon Generals in Bethesda, and about, I guess he was at Walter Reed actually, and talking about what this model is. And he just looked, he said, well, this certainly passes a common sense test. And we kind of chuckled about that, but honestly, it's so much more than that. It takes a lot to change the system, as you can imagine already what it would take to start to implement this. So the beginning step is really forming a steering committee, very important component. And we have a planning guide that takes the steering committee step by step through how to set this up. Is this a system change work? And system change work is very difficult. So it would sort of look like this. And if you think just briefly about what it takes to run a system, all the different components that are part of that. But first you need a coordinator who's going to coordinate a key committee composed of the people who are responsible for some of these major areas, because everyone needs to be on board. if a woman goes and says, well, I'm going to have my next visit with a group that's starting, and the person at the desk says, oh, really? You're going to do that? She's likely to say, well, maybe not. So everybody needs to be part of the excitement of getting this going, and that takes some work because on the surface it may make a lot of sense. But actually, it takes a lot of work, and the idea would be to set it up so it can be sustainable and that it won't be subject to a new administrator coming and saying, oh, we don't need that anymore. So it's still quite vulnerable within the system. So what are their institutional barriers, how to staff this? Remember, we talked about a clinician really owning the group. So you need to have two facilitators, one being a clinician and one being a second person helping. That person could be actually a medical assistant, it could be a social worker, it could be one of the nurses. But you need to have two facilitators, need to get buy-in and find the right space. Space, as you can imagine, is often a huge barrier. Finding private space that it welcomes the sharing of very personal thoughts that many of the women have and perhaps have never shared before. In their provider barriers as well. Training is needed. How do you go from needing to answer everybody's question to facilitating listening? Oh, that's, I think, a very common concern that you've just brought up. And I'm guessing that some of the other women in the group may have that same concern. Is that right? And then it opens to discussion and the group talks about it. So you not answered the question particularly, but the answers are coming out of the discussion with the members of the group, and then you come back and say, we've had a lot of discussion about this. Do you feel that that's given you some ideas or an answer to some of your questions? And maybe she will say, yeah, absolutely. Or, but I'm still wondering about. And so the discussion continues. It's also means for the participants that the group starts and ends on time, which may be a little different for them. So this is going to meet from whatever 9 to 11. You look at when the buses arrive, etc. And they know it starts and ends, on time. So trying to get there on time. And of course, all of these names, instead of putting one person in at 9 o'clock and another one at 9:10, you now at 9 o'clock are putting in 10 names or however many make up that cohort. So, but that means that, are there support people who could come and be part of this? What am I going to do with the children? This is not really, it's not a child-friendly model. That is, children maybe maybe the system needs to figure out a way where children could be if it's impossible for the participants to find care. Um, One of the things I learned early on was that once you're two, you can't be counted on for confidentiality, and that's one of the big issues in group, right? That things that are said confidentially and are not repeated outside, and so having that stable cohort and all is important, and children really should not be privy to that. So, there are issues for the participants. But on top of all that, there are all sorts of, there are questions that will arise. And I often think about the papers that you may be working on in med school or residency, or you're attending and you've got a lot of things to think about and issues, and there's so many things to continue to look at. It becomes a very rich time. Oops, sorry, for you. So, um, there's thinking about it. So why are we finding the results that we are? I mean, even that very first, remember the very first thing that we found was was that babies were bigger. Now, what's happening here that babies are bigger, for example? So you end up having, I think, a lot of questions. So just a little bit about the European Union funded study that we just completed at 2000 to 20, it was 2020 to 24, those 4 years, and you know what was happening during those 4 years. And I think we all still think it was amazing that we were actually able to conduct this study during that time of COVID when everyone was trying to figure out how best to respond to something that was quite problematic. So, what happened here was that this became a consortium developed through the funding from the European Union, and there there were nine different units or institutions that were part of this. Some of them were nonprofits, some were from different universities, and it became a very vital group where we all learned from each other because each one of us took one component of the project. And we were the only, Group Care Global was the only institution from the United States. And we were responsible for the training in all of these 7 countries. So we had a big job, and we were really very happy with how it went. And all of the countries have still continued doing groups even after the funding has ended. And you know that things have been very, very dire in the US. That has rippled all across the world in terms of funding, particularly USAID has had such a strong presence actually in all of our countries. So there's been a lot of work that is going on now to try to replace some of that funding. But in these 4 years, as we collected data and trained, there were over 250 sites in the 7 countries that actually ended up being active participants in the study. All of them did prenatal care or antenatal care, as it was called by them, and then um, had the maybe a third of those sites maybe started to do the parenting. And and we're calling it group care beyond birth for those 2 years. But you can kind of see these are the names. We these were some nonprofits that were part of it. Some of these city in London or Leiden in the Netherlands or Brussels in Belgium were all part of this. Pearsur also was one of the nonprofits. So I won't test your knowledge of the different flags, but this is where we were working, and it was really just a wonderful experience for us. So some other things that we're finding, you know, the benefits for women and their children, it well, they gain health skill and knowledge, and they're establishing peer support networks and collaborative arrangements, these really close arrangements that women developed with their clinician, which was really wonderful on both ends. There was better attendance. WHO, by the way, had changed their recommendation from 4 prenatal visits to 8. And so all of the sites were really interested in increasing the number of antenatal visits that they had. And it was increasing the coverage for vaccines for the infants. And, support people also. We don't maybe spend too much time thinking about, well, what does that mean? Excuse me, but the support people, the partners, the husbands, we talked with, and they really appreciated getting together, being part of the process of getting information, having an opportunity to talk a little more closely about what birth was going to be like, and just being included in the whole process. Now, I know we try to do that anyway in our visits, but I'm guessing that you're not seeing too many support people, but maybe you are, and that would be great. So what about the health providers, healthcare providers? How do they feel? And so there have been some recent studies that have looked at that. And these are some of the things that came out of that. They really like to create these support networks for women because they see within that the bonds that have developed. I mean, women reach out to each other, they help with childcare, they share extra resource maybe that they might have that they don't even need. They watch each other's children when they're in labor. They, there's this whole community building that is happening during this time. So the job satisfaction generally increases rather quickly. And the whole sense that of empowerment that women are really taking control of their pregnancy and saying, I never knew all of this. So is model fidelity important? Is it important to have those three components in place and do training? So there have been some study of that. What does it really take? And Gresh's recent one identified several items that included this adherence to the three components and good facilitator training and the ability to really respond to the group and issues that the group is bringing up. So again, finding that birth outcomes of women in group care are at least equal. I mean, the care is clearly at least as good as, and usually better. That vulnerable populations, it's really a great model with adolescents, by the way, as you might think, but also the having women who have additional challenges, for example, like diabetes, something in the group. And I had some groups with several women with gestational diabetes, and they would sit together and they'd look at it. They'd say, how did you get blood sugar? What did you have for breakfast? I got you that. There was all of this sharing that would go on. So clearly we still need to get more data, and that is happening as we speak. There are a lot of studies going on and several that are still in process. But what do we still want to learn? Well, does this carry over into subsequent pregnancies? We know that women in the US often come into the site and say, when does the next group start? Because they want to do their care that way again. We think that this may well drive earlier entry into care, that the word gets around the community. This is a good way to get your care and just get in there early so that there's a group space for you. And how does it really impact the rest of the system? Is this a good impact, or what are the challenges for the health system? And can we anticipate some of those and work ahead of time to be sure that we're on top of the ones that are the most problematic? What is the minimal support dose needed? So, how much training is really needed? Our basic trainings that we do are at least 2 days, but if it's possible, there might be some follow-up, sort of almost like continuing ed. It isn't all that easy to sit and listen in a group and not teach. So that is a skill that we didn't learn in our basic education. So it's something that needs to be learned and also nurtured, as it's really easy to get into the teaching mode. Um, so what is the minimal dose needed and long-term sustainability? No, this is a lot of work. And to get this set up, remember back to that, the steering committee and all those different bubble bubbles that were there of things that needed to be attended to. It's a lot of work. It's not, you don't just kind of snap your finger and say, okay, this is a great idea. Why don't we start it? Let's see, we could, if we worked hard, we could be ready to start a group in October. But you want it to be sustainable. So we could think about, we could also apply learning to routine care. Um, we could test different pieces of this in individual settings. We could look at settings that are more difficult. Think of rural care in the rural areas. We have a lot of examples of groups running well in the private sector, but what about when you only have 4 or 5 new pregnant women enter the system every month? Then how are you going to do this? So looking at variations in that to make it work depending on the setting. Um, or there may be a QI effort that's happening within the system. Or you can add other things and test them as they get added. So who knows what maternal immunization is going to look like in even another few months. And if this is good, I mean, if this is better care, and we think it really is, how feasible is rapid significant scale up? Scale up is difficult and needs to be planned. And so kind of looking at that, all right, we're doing it in this setting now, what about this setting over here? What would it take to start groups there and sort of look at what the scale up could be? We know the health system's slow to change, really. I think it's probably really broken. But if it's better care, wouldn't we want it for every one of our birthing families and for ourselves too? It's more fun. It's just and rewarding to do care this way. So I have really always loved this. This is a group in Malawi. Remember, they've been doing groups for really many years now. But what happens there is that women sort of spontaneously break into song at the end of the group. And so you see this. Centering pregnancies brought unity, built relationships, taught us a lot. Show how proud you are. We show our pride in a centering group. When dancing in the centering group, we belong. So this is a typical song written by women in Malawi. So this is a kind of a brief overview of a model that developed in the early 90s, so 92, 93, and continued to develop there. The first group of OB residents to get trained were the residents at Yale. And one of them came to me at one point and said, every resident should do a group, which would be 10 sessions, is how we were set up, that you commit yourself to 10 sessions to do a group, because otherwise, how are we really going to know what it's like for a woman to go through a pregnancy? So it's a model that has continued to evolve and is certainly able. It's flexible enough, and in order to be sustainable, it has to be adapted to fit with any special requirements that the system would have. But it really is a fun way to provide care, and it's a great way to learn about pregnancy and the postpartum period. So I am excited about what's happening around the world. Another several hundred group care sites in the United States But looking at now in 2025, after our grant ended, and seeing that the sites are continuing, that all of these different countries are continuing the groups, although they're struggling often for funding, is very encouraging. So I want to open this up to questions and have a little discussion about this.
Thank you, Sharon. I see that Dr. Sadeghi has her hand up.
Hello, good morning. Thank you for this presentation and this information. I'm one of the PGY2s. I just wanted to say that it's really heartening to hear about a model that is explicit in the bidirectional nature of teaching and learning. And also, a number of times in your talk, you alluded to fun. And I think that aside from, outcomes and both in terms of, maternal health, fetal health, et cetera, it's really nice to hear, a pointed allusion to pleasure as part of this process, both as it relates to, the community and as to providers. And also it's really great to hear a model that is successfully shifting the locus of knowledge production and reproduction, and you know, reinforcing and passing along wisdom, generational wisdom, shifting that locus to the community.
Mhm.
I may have just missed it, and I apologize if I did. But was there any? Did anyone look at the outcomes as it relates to postpartum depression and as it relates to these groups? And again, I'm sorry if I missed it.
Um, so no, there's not a lot of there people who are looking at it and studying it. One of the that question raises for me the piece of it that goes along with model fidelity, and that is in the studies that are done. It's going to be increasingly important, I think, that people use a similar tool to assess. And so there are several depression tools out there, and it's hard sometimes really to compare them. There is, thanks for your question, because there's a lot of concern and a lot of more attention, I think, now than maybe 5 years ago to mental health and the importance of that. And so the supposition is that women receive a lot of support and through the model, and that will have a positive effect on their mental health. So there is some data, and you can find it in several of the studies. We need more data on that.
I see that Dr. Sharma has her hand up.
Hi, Sharon. I just want to say thank you for this beautiful talk and being pioneer of this outstanding work, and continuing to do that. I am Ruchira Sharma. I'm one of the maternal fetal medicine physicians there, and my first hand exposure to centering model was when I was a resident at Case Western. And we had a very robust midwifery division there, run by, I think it was led by Selena Kananan at the time. And we had like a really collaborative model with maternal fetal medicine specialists, obstetrics, everybody. And we were doing sort of a head-to-head model of GDM care, and you alluded to that a little bit. I don't know if the data is clear on it, but I could see basically in gestational diabetes patients, we had a centering group, and then we had the normal routine care, and I could clearly see that the benefits of the group care model. We would actually have the nutrition provider there. We would show them what a balanced plate for a GDM looks like. We would have food there, and it was just a beautiful model. So thank you so much. And I just want to know your thoughts generally. And it just puts, it kind of addresses a little bit the medicalization of pregnancy. And I think a lot about that because pregnancy, while I'm a maternal fetal medicine specialist and we deal with a lot of high risk patients. But in low risk women, pregnancy is just a beautiful and fun and a very healthy time. What do you think about, just generally like the way we care for pregnant women? And I think about that a lot, and maybe centering model is something which addresses it a little bit.
Well, yeah, so we could have a whole day's discussion on that of what pregnancy is really like for women, and what are the things that help to make a pregnancy really work well for the woman. And so if there is good support and there is excitement about the pregnancy, that is one way to approach it, but not everybody is excited, and not everybody has support. And so what happens in the centering group is that it's astounding to watch the kind of support that develops within the group. And I mean, I would frequently admit the next session, somebody would come and they would look around and, what happened? What happened here to Kathy? She isn't here. She was having some trouble, I think, last time. Do you know any? Should we be reaching out to her and all? I mean, it's like the women really start caring for each other, and they often, not always, but often exchange contact information really even early in one of the early sessions so that they can get a hold of each other, because it's like they start to care about each other. When we get to know everybody, we get to care about everybody. And it's so I think yeah, I mean, to your point, it's I mean, why so I don't want to sound too strong about this, but why wouldn't you provide care this way? And why wouldn't you get care this way? It's just, it's a time to celebrate your pregnancy, but also to look at the many challenges that pregnancy brings. So I mean, yeah, I guess I'm a little balanced, but you know what? I've watched this now for years in all of the places that are doing this, and it doesn't matter where somebody lives or what their background is, whatever. This is that we're meant to be. I guess it's Margaret Wheatley who had that quote that I thought was right. We're meant to be in conversation with each other, and that's what happens in centering groups.
Thank you.
All right. Well, Sharon, thank you so much for this excellent talk.
Well, it's been my pleasure to be with you. I always enjoy talking to my OB colleagues, and maybe this will be the spark that will continue some discussion of could we do groups here. So I'm all on all of that, and best wishes as all of you are getting going with another year of learning and of care.
Thank you so much for this amazing talk. This is something that's kind of been in my mind for a little bit. And we may be reaching out to get some guidance from you as we're trying to turn that spark into a little bit of a fire here. So really appreciate your experience and wisdom that you've shared today.
Okay. Well, thank you too.
All right. And with that, we're going to conclude. I thank everyone for their attendance this morning, and I hope everyone has a safe and successful day.